And so because the tricyclic antidepressants were so problematic in terms of their side effect profile, the SNRI superfamily was basically put through developmental medicinal chemistry, and we came up with the second generation SNRIs. And these drugs are better than tricyclic antidepressants. And the drugs in this category include venlafaxine, desvenlafaxine, and duloxetine. And these are more specific for the dopamine and the norepinephrine reuptake pumps than they are for the serotonin reuptake pumps. And so it's interesting, as the chemistry improved, the selectivity for the serotonin component of that reuptake pump dropped out, and then with it, as it dropped out, the selectivity for the dopamine component increased. And so classic TCAs block serotonin and norepinephrine, as well as other receptors, and that the other receptors is really where most of these side effects and toxicities come from the previous video. So all of these are due to basically off target. So alpha receptors, histamine receptors, muscarinic receptors, etc. These second generation drugs really have only selectivity for the dopamine reuptake pump as well as the norepinephrine reuptake pump. And so these are more catecholamine, if you remember from the previous couple videos, and these are both indolamine and catecholamine. So from a chemistry standpoint, that's that explanation. Venlafaxine, as I said, offers a mechanistic blockade of reuptake affecting norepinephrine and dopamine. There is still some slight serotonergic activity. That affinity was not completely lost, but it was severely restricted. There's also an indirect effect on the opioid receptors, but there's no effect on the acetylcholine receptors. There's no effect on nicotinic or adrenergic receptors, in spite of the fact that they can block the NET transporter. So what does this mean? Basically, this is a better and newer improved version of imipramine, which is your classic TCA, with less side effects. And so what are the side effects for venlafaxine? Nausea and vomiting, dry mouth, sexual dysfunction, and sweating. Okay. And so venlafaxine has the same clinical outcome as the previous group of drugs. We see a reduction in the frequency of panic attacks. The severity of anxiety is reduced, and there's a degree of phobia avoidance. One thing I do want to point out is that there is a very stern black box warning, and basically this says is that this drug has been shown to really promote suicide ideation in very young patients. And so if you've got a young patient, this is probably not the drug for them, as it can really potentiate suicide ideation. And so there's a very strong black box warning. And Dr. Dance will talk about some of these black box warnings either in his videos or in some of the live sessions. Kind of newer and improved version of venlafaxine is desvenlafaxine, and so this is just a structural modification of this drug, which is shown there. This structural modification basically makes this more selective to norepinephrine and serotonin, as well as dopamine. And so the only difference here is that this particular modification is biologically active. The previous drug needed to be biologically metabolized by the CYP enzyme system. If you've got patients on multiple drugs, obviously that's going to be setting them up for drug-drug interactions. This drug is biologically active, meaning this is administered and it's already active. It already does something. It doesn't need to go to the liver to become activated and biologically useful. But like its parent or grandparent, it also has a black box warning in terms of suicide ideation. The next group of drugs are the tetracyclic antidepressants, and the prototype here is mirtazapine, and I think we'll just talk about mirtazapine. Yes, I see that. I'm making fun of myself. We try not to make study guides that are useless, but I know sometimes it feels like that. these tetracyclic antidepressants, and mirtazapine is kind of the prototype, has a lot of mixed activity. It's got alpha-2 antagonism, it also has serotonin antagonism as well, and it also releases norepinephrine and serotonin as well. Amoxapine and protoline are pretty similar to the tricyclics. They have some anticholinergic activity, and they also inhibit D2 receptors. So they're basically a mess. Mirtazapine, though, and we'll focus on this one, lots of molecular targets. Remember, 5-HT2A antagonism is kind of the prototype for a dampening of some of the firing within some of these more active serotonin regions of the brain. There's also a GABA component as well. This might lead to signaling on neurons that are postsynaptic, causing an increased release of neurotransmitter from postsynaptic neurons. So basically what we're doing is we're inhibiting the negative feedback loops on the surrounding tissue. The alpha-2 antagonist has been explained in previous slides. H1 antagonist is really associated with the sedative effects. And this really, the reason this drug works is that typically depressed patients have more 5-HT2A postsynaptic receptors. And so remember we said there's a reduction in serotonin globally. These patients have a corresponding increase number of serotonin postsynaptic receptors because their body, their brain tissue is looking for that serotonin. So the only way it's going to find it is it's going to increase the number of receptors to increase its chances of even finding some of these molecules. And so that's kind of why this drug works. There is some pharmacokinetic metabolism to be concerned about through the enzyme P450 system, and the side effects are relatively mild. Sedation and weight gain seem pretty mild compared to some of the other side effects that we've been talking about. And last but not least is a unicyclic antidepressant, and the prototype here is bupropion. And from a mechanistic standpoint, we're not exactly sure how this works. It's a norepinephrine and a DAT reuptake inhibitor. It may also assist in the presynaptic release of norepinephrine and dopamine, like mirtazapine. There might be some mild stimulatory properties coming from some type of dopamine agonism, possibly. The norepinephrine effect is much more pronounced than the dopamine effect, and there's some nicotinic receptor antagonism as well. So where do we use bupropion? Well, typically for depression, with some caveats. We can use it as a smoking cessation aid, but clinically it's been shown to be about as efficacious as SSRIs for depression, even though we don't really know how it works. There's been some efficacy shown in the manic episodes associated with bipolar disorder, and it's got a weird metabolism that's centered around CYP2B6, which is an enzyme we haven't really mentioned. But patients really don't mind bupropion, which is the generic form of Wellbutrin, because there are less sexual side effects with this drug. So that concludes our introduction to the tetracyclic and the unicyclic antidepressants. We will move on to another class of drugs that you guys are more familiar with. If there are any questions, please email, and we will actually come back to some of these drugs in the next couple cases in a little bit different kind of detail.